Okay, friends. I don't have that long, so I'm going to run out here on time because I got a meeting after, so we're going to get going. For the people who are not here, I have no idea what you can see. I warned your organizer that I do this on a whiteboard and I don't do a PowerPoint. I apologize if this does not work remotely. I warned them that, from my point of view, probably would not work very well. Which is why I asked for all of you to have a person. Thank you, those who can make it. I know not all of you can, but some people are away. Anyone who doesn't know me, and I'm not sure I actually know. I'm John. I'm one of the ICU docs. And today I'm yes, hey! How many ICU cleaners do I have in the room? One. And Maria's not here. I don't know if she's online because that would have made two. Paul, so maybe so Paul. I don't know Paul is the ICU or ER. Good. Good for Paul. I think he's going to be contract. Sorry. So the ICU cleaners at some point will actually have to know all the definitions to find the real physical studies that's behind, because two Royal Colleges from now you can be asked about it. For the rest of you in the short term, you actually don't, I don't care if you actually know the studies, you don't actually have to know the ARDS definition, it's not important. What is important, I think, out of this is the core concepts that we use ARDS, which is the extreme of the lung disease, that really ICU was built all around. The entire history of ICU is about caring for ARDS. And we've built out a style of ventilation that has become what we do normally. And things that we sometimes get frustrated that don't happen outside of the ICU. And so we're going to run through some of those concepts and how to apply them overall. If we take care of anyone's lung disease situation. One of the reasons why I tell a lot of learners that come through with me that sometimes you notice ICU, respirology, NICU, we don't talk to each other always very nicely about ventilation. And it has to do with these core concepts. Our entire literature is based out of ARDS. We are the only ones who take care of ARDS. NICU's entire literature is based out of APD, and that's how they base everything on. Respirology is chronic ventilation in chronic disease, not acute disease. So we have three totally separate starting points. So it's not surprising that we don't always agree on what the answer is, because we also usually don't read each other's literature, because you'd be starting from too far back. First, very basic starting point. Anyone know why you get hypoxia when you get lung disease, when you get a pneumonia? Thank you, Ms. Mitch. Great. What's up?
So it means that you have blood flow to areas of the lung that are not adequately ventilated, so you don't actually get oxygen from those areas.
Yeah, so if you have the alveoli, you have unoxygenated blood that's coming by them. And what you're supposed to have is little oxygen molecules that are getting down into your alveoli. And they're supposed to diffuse across into this unoxygenated blood. The oxygenated blood picks it up, becomes oxygenated and all mixed together. And when we have lung disease, something's gone wrong, and we have some sort of pneumonia, and this happens, there's no oxygen getting in there. The system can go wrong. Now, if the system's working, what is supposed to happen? If your vasculature is working properly, do you always get desaturated with every little clot of lung disease? No. Because what's supposed to happen? Yeah, what do we call that? Hypoxic vasoconstriction. Alveolar hypoxic. What's supposed to happen is this shuts down. So now all of your blood is coming from here and you're still fine. There's no problem. That's why not all of us actually have perfect lungs all the time with saturated blood. It's also why at baseline, the more your cardiac output goes up, actually saturation tends to drop a little bit. Because if you remember way back to medical school, you have those vast zones of your lung. Some areas of your lung are well ventilated, some are poorly ventilated, some have lots of blood flow, some have little blood flow. And the way our lungs build, it tries to send the blood flow to where the good ventilation is. Good ventilation is, that's where the oxygen is. The more we crank your cardiac output, the less the blood can fit just in those specific spots and starts to go everywhere, including places like the low apex of our lungs, where there's not always good ventilation, so there's not always fresh oxygen sitting there. So just by cranking your cardiac output, we start to mess with the system. And the other thing that happens when we get disease is disease doesn't always stop at the alveoli. Sometimes we get inflammation and we get what we call endothelial failure, which is a catch-all for things go wrong. Endothelial failure, the ICU way of saying things don't go the way it's going to. Because at the end of the day, everything comes down to blood vessels not working. When you have endothelial failure, what happens instead of this lung constricting down, keep going through. And then you end up with your perfect. You end up with mixed left. And that's why we get hypoxia or hypoxemia in this situation. Does we know the difference between hypoxia and hypoxemia? What? Or you said yes?
Yeah.
What's the difference?
Okay, so hypoxemia, low oxygen levels in the blood, hypoxia, low oxygen levels in the tissue.
So yeah, lack of tissue is not getting sufficient oxygen. So it's a functional state difference. They both in low amounts of oxygen. In one of them, your tissue feels stressed by that. It feels like it's not getting enough. And the other, your tissue doesn't. It's still getting enough. Our classic examples of pediatrics are people who walk around with hypoxemia all the time, not hypoxic. Acute, so not cardiac. Why aren't they hypoxic?
They're ventil, like they are getting the problem is not oxygenation in application at the lung level. It's due to like.
So the problem is oxygen delivery is not saturation. So you're largely. So we think often when we talk generically about these things, we say their sats are down, oh god, they're hypoxic. But oxygen delivery. Anyone ever heard me talk about the equation of life? Don't give God before. Anyone remember what it is? I'll give you the constant.
Amount of oxygen hemoglobin.
Hemoglobin, so how much oxygen you can carry times how much of that is down times
Cardiac.
This is all about.
cardiac output plus some sort of crap that we don't care about. Unless you're in a hyperbaric chamber, it's not. So we concentrate when we talk about lung disease often on this. But I think what you're trying to say about our kids who sign out of heart disease and sometimes with our intrapulmonary shunts, what's happening is they have all the usual blood going through the lungs and taking up all the usual amount of oxygen. And then they've got a second source of blood coming through, which actually still has oxygen content in it. You're taking all of this oxygen plus all of this oxygen. So actually your cardiac output is pretty good. And that starts to make up for the fact that this average number is dragged down. But if this number is good, and a lot of those kids have their hemoglobins tend to go up, and this number is really good, it actually doesn't matter if that goes bad. And it turns out in most of us with biventricular hearts, one of the problems actually becomes our hypoxic vasoconstriction. Because as we turn blue and we have lung disease, those vessels start to clamp down. When enough of those clamp down, what happens to your pulmonary vascular resistance? If I keep clamping down passages through the lung, the resistance goes.
Yeah.
So how hard does your right heart have to work to get blood through? Harder. What does that do to your ability to mount increasing cardiac output? And your myocardial work with that. So we can't, most of us biventricular hearts don't have the same ability to just crank everything else to make up for low saturation. It's a very different situation than some heart disease. It means they're still vulnerable because they've got to do all sorts of extra things to compensate for this. But they don't have the same restrictions that people have. Easy so far? A lot of variables. We'll do the bad thing that we're not supposed to do. That's officially not Okay, ARDS. Anyone know what the definition of ARDS actually is? So acute respiratory distress syndrome, yes, that's what the acronym stands for. So it has to be some sort of inflammatory insult. Does it have to be lung-based? That's a very good question. So the obvious thing, no, it does not have to be lung-based. So it doesn't always have to be lung disease. You can have a septic joint, you can have trauma, you can have whatever you want that causes inflammation in the body. And within a week, you start to get lung changes. And those lung changes have to include? Used to say bilateral, now we actually, it doesn't have to be more than one of these definitions, but that was a traditional definition here. The bilateral or unilateral infiltrates. Right?
Feel like acute, I guess, like there's one about 7 days.
Does that be within 7 days?
Sorry.
It's good? No, it's all good. So it can't be explained by the original disease. They have to be on respiratory support, so they have to be on positive pressure. And despite that, they still have to have high oxygen and airway support. So the way we currently measure that in pediatric ARDS is by oxygenation. So you know what an OI is? Because you will be able to calculate this kind of for exams, especially for NICU stuff.
Airway pressure times FiO2 times 100 divided by
What you're doing to oxygenate divided by what you're getting for it is the easy way to think of it. So what you're doing, what you get. And so the lower the number, the better things are. The higher the number, if you have to do a lot and you're getting very little for it, this is just FiO2 is like a number 21. You do 0.21. If you have to do a lot and you get a little, the number goes up and that will be back. Okay. Core concept of ARDS. Which starts you with a pair of lungs. You have some lung that ends up collapsed. You have some lung that ends up diseased. One collapse over here, you have some disease over here, and this collapse over here. A little bit of healthy over here, a little bit healthy over here, a little bit healthy over here, a little bit healthy over here. So your normal healthy lungs get reduced to this relatively slow volume. In the adult world, what they started calling that was the baby lung. Because you take an adult patient, when they start doing CT scans, this initially, the part of lung that actually looks normal is like the size of babies. It's like visible numbers. So we started referring to this as baby lung. What does that mean in terms of how we breathe and how everything works? One is things are shunting like crazy because the hypoxic restrictions fail because the whole system's gone bananas because too much. It also means that when we are pushing air in the lungs, there's a ventilator, you're pushing pressure in. Where does that tend to go? Where does that air that we're pushing in go to? Yeah, it goes to the easy part. Lungs, like we just said, are not heterogeneous. We often talk about them as a balloon, but they actually are as a bajillion individual balloons. And a balloon, when it's collapsed or diseased or full of crap, is really hard to start inflating. Once it's already inflated, it's easier to move and it's more flexible. So when you start pushing something in, the air doesn't go evenly through everywhere. It goes when we push it in preferentially to the lung that's already open. There's a problem with this when we start pushing air into these patients when they're really sick and they're ventilating. What's the problem? We say the air goes to the good lung. Isn't that a good thing? That's where the good lung is. What's the problem? If we treat it like normal lungs in terms of volume and pressure, we're pushing really hard. We're pushing on the only good lung left. And what happens if we push too hard or treat that one too badly? Well, shit, now what lung do we have left? And this is one of our core problems. We have very little lung to work with, and if we lose it, we're done. And this is where a lot of our anything so far? So early on in the days of ARDS, what we learned is people very simple things. We put someone on positive pressure, we help hold their lungs up. PEEP is not, a lot of you are taught that PEEP helps recruit lung. Is that true? Why does PEEP actually help them? Does it recruit lung itself?
Protects the recruited lung.
Yes. So there's something called hysteresis of NCS. When we first have, this is volume, and this is pressure inside the lung. When you have a collapsed lung, so no volume, you put pressure on, it's like a balloon, nothing happens, and it slowly starts to inflate, then suddenly you get to that nice flexible part, it inflates really nicely, then it starts to get overstretched, and inflation slows down. One of the amazing things, because of surfactant, the way our lungs behave, as you drop pressure, it doesn't just fall down the same line. What happens is actually it holds itself open much more easily once it's already open. And the gap between like the same two different pressures, one of which is much higher than the other, you can get the same volume. And the trick is once it's open, it actually takes less pressure to keep it open or stay at that volume. We call that gap hysteresis. It's the gap between the pressure you need to open it versus the pressure so the lung closes out. And larger, that's really surfactant driven. Is why things like not having surfactant is surfactant driven. What this means in terms of PEEP is you don't blow open a balloon at the lowest pressure you put into the balloon. When you're blowing the balloon, it's not the break when you're not breathing into the balloon and you're just pinching the tip off. That's not what makes the balloon bigger. That's what PEEP is. It's holding pressure at the end of your breath. What actually inflates the balloon is the peak pressure or the top of your breath that you put in. And then what PEEP helps you do is as you stop breathing in, or you let your breath go, or you start, pinch the balloon off, catch your breath. It doesn't let the system collapse back down. And there's a couple reasons we really don't like collapsed lung. Why is that? One of them should be obvious. Take the answer right here. What's the other problem with letting lung collapse? Especially in younger lungs. Yeah, it turns out it's terrible for your lungs. So if we open and close your lungs and let them keep slamming shut, we actually shred your bones and your lungs and turn them into bloody pieces of meat. It's actually one of the earliest papers in ARDS. It wasn't even ARDS, it's just ventilation when we first started ventilating people. It was, if we put PEEP on a ventilator, people live way more often when we ventilate them, even if they started with healthy lungs. Yay, we're figuring this out. So that was about the 1950s, the 60s, when we figured that out. Like PEEP actually stops lungs from turning into shredding bloody things that are really gross. Because it stops that what we call atelectric trauma or biotrauma, that repeated slamming shut, and then that shearing having to rip them back open. So that's that one. So PEEP helps us not fall down, not to recruit them up. And what we realized early in ARDS is when we put PEEP on, the more PEEP we put, bigger the lungs got. Right? The only problem being, if you make them too big, our good lung ends up here. So then what we struggled with for a long time in ARDS is, well, we have these crappy heterogeneous lungs. We don't want to be down here and collapsed. We don't want them overinflated because over-distending, it turns out, it also causes trauma and damages our lungs. We want to live somewhere in the middle. So what PEEP do we set people to who have sick lungs? And in ARDS, what do we say? How many of you taken care of patients in ARDS? What have you seen for PEEPs? Is there a number? We started beginning, this is a heterogeneous disease that is highly variable from person to person. All this lung makes it different. We actually don't know what the right number is. You'll often hear us talk about PEEP titration. There's not one thing to do. What we have to do is we look at the kid in front of you, look at the patient in front of you, figure out what makes that patient happiest. And in the case of a really sick patient who we have intubated and sedated and muscle relaxed and ventilated, what that means to us is not do they feel okay and are comfortable with us. Definitely comfortable a little bit of that. It's how stretchy are lungs, how easily small pressure changes do we get nice volume changes, or do we have to do big pressure changes and get small volume changes? We have to do big pressure changes for small volume. That is that. If we have to do small pressure changes for good volume, that is good. What PEEP gives us the closest thing to this, and that's what we target. What's irritating about that is there is no one number, and the patient's number today doesn't have to be the number tomorrow. It doesn't have to be the number at the end of the shift. But it means we have to always respond to the tendency products. We try to do as little damage as possible. So far. Very long ago. One of the things, one of the things we often worry about in the ARDS sedation is position. Head or belly.
Oh, I see.
Nice. It wasn't obvious. Come on. We worry a lot about patient position. And one of the things that we get frustrated with sometimes we see on the ward is someone who's got CP, they've come with viral illness, and they're unwell, and parents came in by ambulance, they don't have their wheelchair, what happens to that patient for days and days on end while they're in hospital? They lie, and we come by and go. The reason we come by and do that is why? What's the problem lying down? Yeah, so gravity works all the time, you'll keep it for a second. And gravity pushes your belly down. It also pushes down through your chest. So the part of your lung that feels the most gravity impacts is the back part. And your belly, which you're pushing down, pushes up on your diaphragm. The part that's getting pushed on the most is posterior part. So this part of the lung gets a double whammy from your diaphragm pushing up and gravity and everything pushing down from the lung. What's your best vascularized and usually best ventilated part of your lung? Hey, you know, isn't that exactly where it feels the worst effect of gravity? This is why I like it. And when someone has ARDS and we've got them ventilated, one of the things we do is we sedate them. And what happens to your muscle tone when you sedate them? Go through your diaphragm, it's further pushed. I mean, there's more lung. And then if you're really sick, we go, oh God, we should muscle relax you to make sure you behave yourself. And then what happens to your diaphragm? So it works. So a long time ago, 1972, I think, there was a guy sitting in part of the rock said, this is a problem. This isn't a good idea. Maybe it would be a great idea if we turn our patient over. What happens when we turn our patients over? Capital upside down. Now gravity's going this way. Who's seen this prone patient? Where do we put the support under the patient? The belly hand. We have support here. Support here. So this actually no longer going down to the bed, which means push it down, which means how much pressure is there on the diaphragm? Where is it? Which means also gravity then starts to pull this open. The gravity now, all this class 1 before is now being pulled down by gravity, so it starts to open it up, which is an amazing fact for the patient's ground. There's an added benefit of prone patients that has to do with the bed is here, and the spine is here. What's that matter? It's a terrible because we kind of flatten them and we don't want to do properly. All the things we don't want to get out. But we said early on that the open lung is the one that wants to stretch. The push area tends to go where it's easy. Well, now we have a physical restriction on this side because this is rigid. We have all the weight of the patient sitting on their chest. So that makes the front part rigid. So this good lung that's here, how easy is it for that to just push and expand? Not easy at all, because it's got to lift the whole patient up. So what that does is that more pressure is coming in above, now more evenly distributed everywhere. So not only the gravity pulls open, but you actually have better distribution of the air that we're pushing in, so you get better lung movement. Just by having partially restricted the chest wall. It's a new bonus. This is why we prone patients. It's also why we don't like patients who are sick to sit still and lie flat on their back. We like them up in their chairs, we like them in parents' arms. We're obviously not going to quite code them the same way, though actually when we learned with COVID, we have tons of these patients. Actually, lots of patients that can get away from never doing some poor risk at all. It's the first time we had enough patients, enough numbers, and they were sick enough that we could prove in the adult world to split them, even if they're not muscle relaxing, we can still save lives. Moving patients matters. This is what we can. Easy. What was that?
Like, why is it all kids on iPhone, like, riding the bike down the?
That has to do with condition. Some of this has to do with even why people on the next one, we know that we don't tend to disconnect this. It turns out even if we fix your gas exchange perfectly, you don't stop breathing. And if you keep breathing, you've got you off eventually, the lungs are going to stack, lungs are all collapsed. You still try to hold on to it. And that damages your lung, which means that they has to be built back. So we tend to still keep them on some form of ventilation. So much is the right much, and how much you do. So we make things up. We usually tell when we make them up. We do things like rate of 10, peak of 10, pressure split 10. 10, 10, 10. Oh no, we're going to be different. 10, 10. But that's why we still don't have those questions. It's good they're good. Now, single most important thing that we do that we've ever learned about ICU, I should say. We have our sick lungs. We have that. We said the little patches of lung that are good, and everything else is terrible. So we have these tiny little patches of lung. One of the things we learned going back about 36 years ago, going to be a while, 1990, was when we have tiny lungs, it turns out you probably shouldn't try to make them big. You only have a little bit of lung, and you push them hard enough to make all of your numbers normal. So if you know like the term euboxemia. When we run a gas and we want every little box to be normal and no red flags, and we have our euboxemia, it turns out that's terrible because we're asking in an abnormal situation, we're asking for normal results. What's the ICU term we use for that? Permissive hypercarbia. And what does permissive hypercarbia mean?
Things behind your CO2.
Yeah, how high?
It's like the pH decreases.
Yeah, the answer for CO2 is don't.
Okay.
Don't care. Don't even care a little bit. All I care about is the pH. And why do I care about the pH? Yeah, at some point you become so acidic your heart stops, and it turns out that's bad for lung recovery. So we have to ventilate you enough to keep your heart working. How much is that? How many of you seen patients with 6.9? pH is 6.9 coming out of 12 left. How many of you ever seen a patient who's got CO2 of 120 and their pH is sitting at 7? 100, whatever number it is. It happens, and they often live. There is a certain degree of how low can we go. Oh, depends how healthy the heart is, depends on everything else. But we don't like to push our luck more than we have to. So usually what we say is, okay, we're not going to target a CO2, we're going to target a pH of 7.25. If it's really hard to get a pH of 7.25, what are we going to do? 7.2. And if it's really hard to get a pH of 7.2, what are we going to do? 7.15. And if it's really hard to get 7.15, what are we going to do? 7.1. Because if we're there and we have 7.1, and the patient hasn't arrested, hey, they can tolerate 7.1. It's the magic of how we produce the right? So one of the things that we've learned is don't do more than you have to keep the patient alive. And the original data where they did it, they went from normal CO2s to targeting a pH and letting it, I think the original paper used pH of 7.15. Mortality dropped by 50%. So it's not a subtle difference in terms of the outcomes. It is massively different. Now, we don't really know what the right number is. We don't really know how far we can let it go. But one of the things that comes out of this is ARDS doesn't go away by controlling the CO2. ARDS goes away when the lungs heal. Us beating the crap out of the lungs to get a number on the screen, it turns out doesn't help them heal. It's right up there with kidneys. Kidneys are the only organ we feel like if we make it work harder, it's going to get better faster. We learned in the 90s, lungs, don't make them work harder if you want them to heal. So we back off, and we back off as much as we can and let them heal. This is very different than the phone call we usually get from everyone else in terms of how we're dealing with CO2 ventilation. Because everyone in this room, including me at various points, has had a patient with bronchiolitis or pneumonia, and they've been breathing fast, and someone has said, let's do a gas, and the CO2 comes back at 55, someone goes, they're respiratory failure, you must go on more support. One of the core tenets of what we take out of air gas literature, which is the extreme, is the CO2 does not matter. This is one of our biggest differences with respirology. They're dealing with chronic diseases that are not expected to go away. A chronically high CO2, it turns out, is not good. But in a short term, we don't care. Because it's not bad for you in the short term. And all we're waiting for in our management, particular management, is for the disease to go away. Usually to go away in spite of us, not because of us, because everything we do actually causes more harm. So we're trying to do as little harm as possible while waiting for the kid to just get better. And then the disease goes away, and then it doesn't matter that their CO2 was living at 95, because their lungs recover, they blow it off, and they go back to normal. And life is good again. This is what drives a lot of us nuts about when we get these CO2s, therefore we must escalate the star transport. It's the exact opposite of everything we want to get through. Now, there's key differences between a kid on the ward and someone intubated, sedated, and ICU. Among those differences is the sedated part. Because if you can't breathe and you're breathing insufficiently, your CO2 is going up. Often, though not always, how does the patient feel? Terrible. It does not turn out feel nice to feel like you're suffocating. That is not a nice feeling. So we don't like kids to be uncomfortable. So if your patient looks like they can't breathe, it's distressing to them, like a bug-eye, a tachycardic, that is unacceptable. The CO2 is irrelevant. If the CO2 is normal and they look like that, it turns out it's still not okay to leave them like that. Other bit that we see, whether or not their CO2 is elevated, they look like they're working so hard, they look like they're giving themselves CPR. Probably not a long-term response. So there is a degree of work where we also do independent of CO2. The important thing for both of those situations, neither of them actually has to do anything to do with what patient's CO2 is. One of the biggest reasons we order gas is on the board. All of you, like anyone's worked with me, all of you have done it. Let's do a gas. Patient's working hard to breathe, let's give a gas. And usually we say, sure, go for it. So why do we do that? Well, often it won't. That's what I say, so why do I let you do it? Because I've let you do it.
Yeah, so that I learned. I was like, so that I
Do
would
you
say
have
that's
to actually
learn.
Is that the lesson most of you have taken away from why we let you do this? There's usually two reasons why we let you do it. One is often we're not there. And we don't know all of you very well. Most of you don't see it actually in the sick patients bringing that respiratory disease because it's pediatric, it's actually relatively rare. You don't have a great breadth of clinical exposure usually in that area. So one of the things the CO2 can be very useful for if you're not there is to give us, when we can't see the patient, an idea of how sick the patient they are. In general, the little kid with bronchiolitis with CO2 is 60 is usually, though not always, sicker than the one with CO2 is 4. The other reason, it gives everybody something to do when people feel good about investigations. Okay, the kid looks bad, we're going to do a gas, do a chest x-ray, and make them NPO, right? Like that's kind of the triad that people do. How often do we then actually do anything? But totally feel better as we get. So sometimes what we're actually doing is a bit of a gift to let people feel like, and their parents as well, see that we are doing something, that we're taking it seriously, even when we have no intention whatsoever of reacting to the information. The extreme version of this, who's heard me talk about asthma? So the patient coming in to emerge with asthma and extremely really happy puffing, tripoding, silent chest, or looks like they can't breathe. Some steps go on, so they don't hear very much. How many of you have seen a patient like that? 1, 2, close. Some unwell asthmas. One of the first things that happens is someone slaps the ventilator on the kid's face, and then someone puts in an IV and drops blood work, including the gas. If that gas comes back and the CO2 is normal, what do people say? That we're worried because maybe the patient's tiring out because they should be hyperventilating. Because actually the most common thing is we do a gas and the CO2 comes back at 32, which actually means they're hyperventilating. And we say we can't hear anything. Chest is silent, they're not moving in the air. Your CO2 is low, that means you're hyperventilating. Something in this chain of logic doesn't totally follow, but we see all the time. If they're hyperventilating, what do we do for them when they look really bad for asthma? So the CO2 is 32, they can say like, what do we do? We treat their asthma. If their CO2 is 40 and they look the same way, and we go, oh God, they could be tiring out. We're really worried this patient could be really sick. What do we do? We treat their asthma. If their CO2 is 90 and they look the same, what do we do? We treat their asthma. Does it change our treatment whatsoever? Do we still do the blood gas? So this is kind of the extreme version of where we see it all the time, that we do these gases, and it doesn't make a lick of difference anymore. But it is ingrained in our soul to run those gases. But again, asthma is a good example because the goal of the treatment is not to treat the CO2, to treat the asthma. It's a variation of what we do in the area of asthma lung disease, treat the underlying disease. If it's pneumonia, if it's septic hit, we go after it, and all the lung damage, sit there and wait until it goes. Okay? That's why we like to do gases. Make work projects. Doesn't that make you feel good? Uh, actually, what was it about?
Oh, not
What was that?
in the emerge, like when I saw that, it made people move faster. Like they didn't move quicker because they were like,
And
oh,
again,
yeah.
because a lot of people often aren't there and do not see the reactions. There is that value of, oh, the CO2 is 90. We should actually take this seriously. Oh, it's great you said the patient looks sick, but we're actually going to believe because the CO2 is 90. There is a degree of that. But it doesn't actually change our management of it. And that's true 95% of the time. The gases don't actually change anything. There's some exceptions to that, and some of the exception is when we sedated and muscle relax the patient, and we can't actually get a sense of is this stressing them? Is this better? Is this worse? Often we have an end tidal, we go on that when the lungs are really sick, even the end tidals aren't that reliable because we'll have dead space. So then the gases are actually useful, because one of the things we want to do with the gases is we don't want to underdo it and let the CO2 go to 200 and the pH that measure low. But we also don't want to push so hard. We're pushing hard with the ventilator. We don't want to be doing too well either. We're pushing really hard with the ventilator. When the CO2 comes back normal, we're actually not doing our job very well. We need to stop pushing so hard with the CO2 drop. Which comes to the question of what is actually pushing too hard with the ventilator. How do we actually touch it? So one of the core things we teach about ventilation is we teach things like, you want this much volume per breath. You want these kinds of things to happen. What's the volume that we teach? You know, there's standard volume that we take in 50 per patient. 6 to 8 mils per kilo. Didn't know where that came from. Early 2000s, someone did a study and they looked at ARDS, ventilating patients with 6 to 8 mils per kilo per breath versus 10 to 12. The Artsnet group, large part of the base of Toronto, that did the study. And so 6 to 8 versus 10 to 12. And the 10 to 12 group died when 10 to 12 is closer to you taking a big breath right now. And it's closer to normal. So that's where we got to 6 to 8. No one has ever looked at really any other volume in a meaningful way. The only thing we know for sure is 6 to 8 is better than 10 to 12 in ARDS. We have internalized that to 6 to 8 breath. It's important for the PICU keeners in particular to remember it's actually not that data is from the ARDS. Because we periodically have patients, whether they have asthma or particular kinds of congenital heart disease, where we want lower mean airway pressures and still good ventilation, and actually we're better off with different volume points. And we're better off at 10 to 12 per kilo. But those, we're so ingrained 6 to 8 is the right number, we don't always know the version. And we don't know that 6 to 8 is better than 4 to 6, or 2 to 3, or 1 to 2. The problem with things like 1 to 2 is what? Your margin of error. But the idea is often less is more. And that's some of our idea where things like oscillators and jets come from. The idea if we can just keep the lung and basically just quiver the lung without really letting it overflow anymore. But that hopefully is helping them. Yeah, we've really been able to prove that it works. So we love our oscillators and jets. Because the idea is so we have the 6 to 8 per kilo. One of the interesting things about that Artsnet trial when I did that is you could reorganize all of their data and say volume doesn't matter. The only thing that actually mattered was pressure on your ventilator was over 30, you died more often, independent of volume. And this gets back to what we said at the beginning with PEEP in terms of the heterogeneity of the disease. What actually matters may not be the volume, it may be how compliant your lung is. If it's easy to do 10 to 12, then 10 to 12 turns out it's probably fine. But if it's hard and you have to push and those peak pressures start reaching over 30, bad things happen. And so one of our cutoffs when we talk about pushing too hard with the ventilator magically becomes peak pressure over 30. Hey. So that's often one of our gauge groups. The truth is lower is better. If you're at 16, you actually sure your CO2 can be normal. Peak pressure 16 is fine. If you're at 25, well, it's starting to get up there. 26, 27, 28, 29, 30. start bringing the bar down. And the higher those numbers are, the more we bring the bar down. And that's some of where we say, are we pushing too hard? We don't always have to have hypercarbia if it's easy to achieve. The moment we start having to do more, that's where we should be questioning it. And again, that comes back to those little kids on the board who we get consulted for. CPAP, BiPAP, oh, but they won't like it. Drug them to put it on. So I'm going to drug the patient to put them on for a therapy that doesn't actually make them better. They really need the therapy. And sometimes the answer is yes. Sometimes the work of breathing is so bad or they're so uncomfortable with the answer is yes. Sometimes it's if the kid looks comfortable. Often it's easier for us to just admit them and then say we don't care, not do it on our own because that gets that's where our volumes and our pressures come from. One of the terms that some of you will hear thrown around now is driving pressure. Maybe you know what that means. Can't go with this. That's intrinsic peak versus what we're actually putting in. But we probably talked about that Who likes ventilator pressure waveforms? Can you tell how I ended up? Most of you have seen in somewhere in the ICU pressure time, something that looks like this. And what that is the pressure over time as the ventilator is going in pressure ventilation. The bottom number being P. And then we add, for example, P, and we went up that hit. It holds that for 5 times, and then comes back up. That's our standard one. So it looks like this. In this, it's really hard to explain what driving pressure is in a way that's easier to understand. It's easier to understand it in volume ventilation. Most of you don't see that. In volume ventilation, what we do is in this, we monitor the volume, and the way we observe that is to say, go to this pressure and hold it for a certain amount of time. At the beginning of the breath, that creates a big pressure gradient between the ventilator and the lung. You get a lot of flow early on, and then that flow accelerates down through the breath because the pressure gradient is you hold that pressure, the lungs start to build up pressure, so the gap between the two starts to close, so the flow that is generated starts to close. That makes sense? So at the beginning, when I put this pressure here, your lung pressure is here. Your lung pressure is here. So there's a big delta. So if you have a big pressure gradient, lots of flow between the two, lots of air moves. As that air, as that air starts to move in, and over time, the pressure in the lung starts to go up. Because you're filling it with air, you're building a pressure. That means the pressure gradient drops, or flow also drops. So when you see a flow instead of a pressure curve on a pressure ventilator, you see the nothing, up, and it goes down. And then it goes nothing, and then it goes up, and then it goes down. Something like that. This is one of the reasons why people argue for pressure ventilation, because that's closer to how we take the beginning of the breath. Get a lot of flow early on, and then as your breath continues, your amount of flow actually drops. People historically argue that pressure ventilation is more physiologic or natural or feels better. I don't think it works, but we work. In volume ventilation, the way things that we control same pi time, we want a fixed volume. The way we do that, we fix the flow. If I want 100 mils in half a second, I'm going to deliver 200 mils per second of air. Because then in my half a second, I've delivered 100. So our flow now was like nothing. That's the one that becomes square. It's the fixed flow over time. So what happens to our pressure curve, running along it, the spikes, falls down, levels out, and then forgive me, that's there. It's supposed to be the same one. Little bit of black at the edge. This initial spike that happens is because when you first start pushing a gas through a tube, the tube has resistance in it. And until that gas is nicely flowing through, you have to overcome the resistance of the tube. This has to do with airway. Once it's leveled off, we call that the plateau pressure. That's once you've overcome the resistance of the tube. You pay attention. Showing off a little in the middle row, that's okay. This is the plateau pressure. This is how much pressure you're actually generating by just pushing the flow in once you've overcome airway resistance. The driving pressure is the gap between peak and plateau. The problem with our pressure ventilation is you can't see the plateau pressure. It's hidden from you. Just the way we generate, because we're generating pressure, so you can't see the airway resistance that you don't have. In volume ventilation, you can see it much more intuitively. And in driving pressure, what we say is what we want. The smaller this number is, to get our volume in, the better. Another way of saying that is you do better when you're at the point where you need the less pressure and the most volume, like we talked about at the beginning of that. So a lot of our modern targets, what we're actually looking for, is we're targeting where the patient has the best driving pressure, is the term we're using. If you really wanted to find it in pressure ventilation, patient with muscle relax, what you can do is you give them their breath, and then you lock the system, so you close off the tube to the ventilator, and you let the system equilibrate over time until it reaches the plateau. Because if I shut down the ventilator right where it is, any air pressure that's in the chest is now a closed box. Because the different parts of your lung set air and pressure at different rates, there's always some degree of lung that's still adjusting to the pressure you put in. So by closing the system, you give it time to level out and let all the pressure go, and then I can figure out what my pressure is. We don't generally do that very often. Why not? Yeah, what if the patient tries to breathe while we're doing that?
Yeah.
We've now just, no breath for you. The machine is closed. Can't draw any air. It turns out people don't like that. It also turns out your heart and your lungs don't like that either. The extreme version of what can happen is closed glottis, trying to take a big breath. Happens in near drowning events, happens when the anesthetist forgets to open up the circuit on their anesthetic machine, the patient's like, yep, negative pressure pulmonary. That's how that is. So we don't do that in patients or previous contracts. So in general, we don't do it. What we do is try to get the ventilator to measure form compliance number. So we used to keep titrating to best oxygenation. All of our modern data is actually doing to the place where the patient has the most compliant one. Probably the best ones. Rather than just the best saturation. So you're not always going to be best.
Sorry, can you go back to the driving pressure and just can you explain it in like a dumb it down for me a little bit? Like what does it actually mean and why do I care?
Okay. Remember the curve that looked as a lung volume?
Yeah.
Like that?
Yeah.
So what this is saying is we want the number between the peak, the plateau pressure and the peak. So when we're actually pushing pressure into the lung, to be as small as possible to achieve the volume one. Another way of saying that is we want to be in the zone of inflation where for the smallest amount of pressure we get the most volume. You see, this is the way you're looking at it here is this is pressure and this is volume.
Yeah.
So I want a small pressure to give me a big volume.
Okay.
What I'm looking at here is I want to say what the smallest pressure it gives me the volume that I want. And how do I adjust what this is? Try different peaks. Because what I'm trying to do then is walk up different parts of this curve.
Are you saying ideally you wanted small driving pressures?
Smaller the better.
Okay.
That's another way of saying smallest pressure, biggest volume. Does that make sense?
The bigger the gap, the more damage you're looking
The bigger the gap, the more that means the harder I'm having to push to deliver that volume.
Right.
The more pressure I'm actually putting on my alveoli. And we don't like putting excess pressure on our alveoli. This pressure doesn't count because that's airway resistance. Don't care about airway resistance. Many of you are talking about asthma. Sometimes like when we have really bad asthma or ventilated, we can have pressure 70 or 80. We don't really care because if you have airway resistance, it's up at 70 or 80 and you have alveoli, but it's 15. So we don't really care about this because it doesn't damage lung. Airway is not one of the counts. But we care about the blood pressure, the alveoli. And so this is another way of saying the smaller this is, the better that is, the more we're actually getting the volume. That becomes our goal. What is the place where the patient looks best? You know, the cheat with all of this is we talk about all of this with positive pressure ventilation. our patients are not always sedated and muscle relaxed. And when patients not sedated and muscle relaxed, what do they do? And how to breathe? Negative pressure. So we're talking about the positive pressure side of it, but the patient can also generate negative pressure. It turns out if we think of our lungs, but if we have our lungs going in, and we have all that collapsed lung down the back, then we have a good lung. When we positive pressure ventilate, we talked about we damage the good lung. Because we're pushing air in, and so that tends to go down. When we negative pressure ventilate, or we let patients breathe spontaneously within the sick lungs, how do they breathe? How do you generate a breath? Diaphragm will do. When we looked at that side view, this collapsed lung is what's right up against the diaphragm. If the diaphragm pulls, it's pulling your most collapsed and usually sickest lung, especially the one on the back. What does that do? It keeps those pulls out the lung here, rips them open. Spontaneously breathing damages the collapsed lung. Positive pressure ventilating damages the good open lung. Turns out you want all of it to recover for the patient to get better. So we don't like patients to breathe too hard on their own. We can't say, hey, look, our driving pressure is tiny. The patients go, that's no good. Because then they're just doing all the damage and we're just willfully closing their eyes. But look, the ventilator number is nice. That doesn't help. So we need the combination of both. Now, if we're really being cute, we can actually measure how hard the patient is trying. We can use what we call an esophageal balloon. We can put a balloon in the esophagus, put a balloon right here, and then that can actually give us how much negative pressure is being created. We don't tend to do that very often because most of the time it's more finicky and troublesome than we like. But it is a way we actually have the ability to go after and look at both what the patient's doing and how much of this is being transmitted into the chest at the same time. And then we can try to marry those numbers in some really cute ways to handle patients or how to help things that are stop their lungs from collapsing. So, things to take away from this. Air, yes, lungs are not one balloon. There are bajillion little balloons that are all really differently. We don't like them to collapse. We don't like to stress them open. We like to do just enough to keep the patient alive to get them through. They don't sit still and sit on their back. And when we skipped over was fluids. One of the only two things ever in pediatric ARDS to show a difference in mortality is how much fluid you give your patient. If they give them lots of fluid and their lungs tend to absorb that fluid, better lungs are sicker lungs. The whole point is we're waiting for lungs to get better. The sicker they are, the harder we have to push on them, the worse we make everything get. How many of you have seen me express my irritation with, oh, the bronchiolitis baby, look at them well, so give them a bolus. They're coming in with lung disease. They're better dry than coming lung disease. I'm sure the rest of them might need some fluid eventually, but I see doctor, I care nothing else. So fluid restrict is one of the reasons why we fluid restrict so much, because it's one of the only things we've ever actually shown actually makes mortality. The other bit about that, all these patients who are breathing hard are on what kind of gases? High flows, CPAP, BiPAP, ventilated. What's different about that than breathing normally? What's different about being on a machine that's helping you breathe as opposed to breathing where you sort of right now? What's different about the air you're breathing? Humidity. How humidified are all those gases? 100%. They are tiny little rainforests plugged directly into your lungs. Which means what happens to your insensible losses if you are breathing fully humidified gas? You no longer actually have to humidify the air. You no longer lose the air. And the more aggressive your style of ventilation, the less water you are losing. Which means your actual water needs also go. Who's your V rail? 421 volts. And you go back. This is one of the two reasons why. It's that actually you don't need the same fluids once you're on. Easy? 2-minute question? I'm sorry for those of you who are aware that I'm probably not going to do that. He gets the catheterals. Probably not. People probably smart enough to make that.
That's true. I think it just, it just, it's more of like a,
Does anyone know offhand how to get PowerPoint onto this stupid computer? You would think that a computer at Shell that's like on a meeting room would have PowerPoint, but no.
Yeah, that's true. You could do it if you want.
Okay.
If you, yeah.
I'm in Citrix.
Yeah, if you go to the first tab, just the geometrical. Yeah. So if you go to the top left, the little square next to you, and then Microsoft Office, I think more apps. And then I think one of them are, like if you keep scrolling, give you the library on the left. Okay, never mind.
Okay, this is.
Let me see if I can do it. Because I think if you log into your personal account, not the regular computer one, it might do it. Yeah, so instead of sign in your own profile.
Where?
Or try this profile one and then log Okay, I don't know.
I can't use anybody's laptop, right? Oh, I can't use someone's laptop to
Well, it won't connect to the.
yeah.
Microsoft.
Yeah, if I could get into Microsoft anywhere here, I could do it.
And then try to log in, maybe not that, or like, I'm really Microsoft.
Well, actually, in the top right where it says install apps,
Oh, yeah, install apps, and top right. But, no,
I don't know how much she loves
Microsoft 365. Hold on.
This is so stupid. I'm gonna log out of all of this crap.
Yeah. Okay, go to that, see the M on the top right corner. The M, you gotta type it. The M in the circle in top right corner.
Okay, better.
Keep going down, just down, the M, yeah, in the circle, yep. Now sign in with a different account. Try using their account. I don't even know when you're
Okay. Now what?
And now if you go to the top left, like it should like you their PowerPoint.
Oh, for Pete's bloody sake.
That's a different login. That's not a login. Go back. No.
Just come and do it. Honestly, thank you.
No. Sorry.
I don't want to forget my passport. Okay. That's not my business. Same PowerPoint, that's a good
Upload a
start.
file.
I don't want, okay, fine, that's all right too. Good. And, that way. No, that way. Okay, thank you. All right. Sorry about the technical glitches. I am going to complain. This is the second time that I've used this stupid computer that is the only computer in North America that doesn't have PowerPoint. So this isn't too long a presentation, so I think we're still going to be able to stay on time, which is particularly important because I've got a haircut booked this afternoon, which I desperately need. So as all of you know, we'll be talking this afternoon about congenital lung malformations and also tracheo-esophageal fistula. Let's start. So this is thoracic part, and this is one of my favorite pictures, the Brophy song.
Not wild.
All right, so with that as a start, we'll be talking about a number of anomalies. We'll be talking about bronchogenic cysts, cystic adenoma malformations, congenital emphysema, sequestration, and then kind of a potpourri of pulmonary aplasia, agenesis hypoplasia, and finally one of my pet topics, tracheo-esophageal fistula.
Sorry, they can't see the slides, so I'm just going to try and share it. So let's window to share. Can someone tell us if they can see it now? Anyone
Still
know?
no.
Still no. Okay. Now?
No.
Oh, Okay, 1 second.
Uh,
What about now?
Yeah, you're good. Thanks.
Okay, perfect. Thank you. All right.
Don't call me Joe.
So, few take-home messages. First of all, congenital lung malformations are all really rare. Congenital heart malformations, and kidney malformations, and such are all common to the stuff we'll talk about today. The second thing is, I'm going to talk about these things as separate entities. They're not really separate entities, and they often kind of flow one to another. You can have a patient where you think they've got a CPAM, but when you take it out and it's going to have an element of sequestration to it, these things, one can blend into the next a little bit. All of you are familiar with Bacterial. So really there should be another L somewhere in Bacterial for lung, because all of these things are also commoner in patients who are part of that bacterial spectrum. And the final thing is all of these things are disorganized, relatively embryonic tissues. I think all of these, just about all these malformations, are associated with a higher risk of malignant change. And that's the thing we're going to come back to. So once again, to understand congenital anything, you have to go back to embryology. So as all of you hopefully remember, you have an outpouching from the primitive foregut at about 22 days of life, and that starts to form the tracheobronchial tree. Eventually, the respiratory part of that is going to branch into 18 major lobules. Then between 8 and 16 weeks, these things bud and branch and form the terminal bronchioles. And at this point, the airways are lined with cuboidal epithelium. And the sixth aortic arch migrates and turns into the pulmonary arteries. Between 17 and 24 weeks, you get canaliculi, which form saccules, which are kind of early alveoli. And as all of you know, that kind of gets you to the point where extrauterine life is theoretically possible. As the blood vessels move into these saccules, you start to allow gas exchange, especially as the alveoli walls start to thin. And then during the last 16 weeks, especially the last 4 weeks before babies are born, you get this exponential growth in the number of alveoli. So once again, this is pretty much what it looks like. You start off with this tracheal tube, which branches to the very beginning of the tracheal buds, and these things eventually branch to bronchial buds, eventually play these into recognizable lobes. So in terms of which of these things are the most common, I think the best study comes from Washington a long time ago. And you can see that in this large study, about 30% of congenital lung malformations were bronchogenic cysts, about 29% were also sequestrations, 15% were congenital lobar emphysemas, and CPAMs were about 7%. So we'll start off by talking about bronchogenic cysts. And bronchogenic cysts, in a nutshell, are big round things. And we look at them both thoracoscopically and also on imaging. So it's a remnant of that primitive ventral foregut, that really initial tissue we started to talk about. And it's really an ectopic bud that comes off of that from the initial budding of these tissues, and that bud ends up somewhere. Now, because this is also early in embryonic life, you can also have an esophageal duplication cyst, which is exactly the same thing but budding off the esophagus. The tissues are pretty much the same. So once again, there's 20-ish% of congenital cystic diseases of the lung. There are about 10% of venous cell masses in children. And because they're so primitive, they contain tracheobronchial tissues, mucus glands, fluid. They're lined by ciliated columnar epithelium. And the walls can contain muscle and elastin and islets of cartilage, all sorts of stuff. So about 88% of them are mediastinal. So they're really central tissues, which makes sense because that's where the budding is going to start. They can also, if they're mediastinal, they tend to be quite symptomatic. They compress your trachea or your bronchi. They can present with respiratory distress, hyperinflation if it's acting as a ball valve in your bronchus somewhere. And especially if they're paratracheal or coronal, you get a higher likelihood of symptoms. If they're para-esophageal, of course, they're going to cause dysphagia, and same with esophageal duplication cysts. About 12% are hilar. They're usually near major bronchi, sometimes more periphery, typically more in the lower lobes for some reason. And you can also get weird ectopic bronchogenic cysts. They've been recorded in the cervix, the abdomen, and the pericardium, but of course, these are all incredibly rare. 2/3 of them are either attached to the tracheobronchial tree by a little fibrous stalk, or they're actually embedded in the tracheobronchial wall. If the budding happens really early, they can contain gastric or esophageal epithelium. Some can communicate with the tracheobronchial tree, most of them don't. The important thing about bronchogenic cysts is they can get bigger. So they can enlarge with air if there's a communication, they can expand with fluid, or they can expand when they get infected. So once again, symptoms are typically symptoms of airway compression, respiratory distress, cough, stridor, wheezing, and so forth. The ones that are presenting with a prenatal diagnosis typically present with respiratory distress. If they're compressing lung tissue, you get lactocysts, you can get recurrent pneumonias. They can look a lot like a lung abscess. And one of our recommendations, when you have a nice classic lung abscess diagnosed at CHEO, they should get a follow-up x-ray at some point. If it's gone away, it was a lung abscess. If it's still there, it's probably a bronchogenic cyst. They can erode, so they can get hemoptysis. And there's been a few cases of malignant change again with these adenocarcinomas and rhabdomyosarcomas. So in terms of symptoms, the mediastinal ones usually present with dyspnea, sometimes with cough. The pulmonary ones usually present with cough, again due to airway compression. So in terms of diagnosis, the diagnosis is usually pretty easy. You usually see these things with a chest x-ray. You'll see this round mass, usually solid, sometimes with an air fluid level, along with atelectasis, mediastinal shift. An upper GI can diagnose esophageal duplication cysts. You could do a CT scan or an MRI. You have to be very careful because if these things are compressing airway tissue, acting as a ball valve, you don't want anesthesia to gain positive pressure ventilation and potentially causing a pneumothorax. You could do a bronch look for airway compression. We don't normally do bronchs with these. So in terms of management, if it's not really classic, sometimes we'll do an MR angio or a CT angio to look at its blood supply. And basically you take these things out. And it's both to prevent and to treat complications. These things will enlarge potentially under low pressure, so in airplanes. There was a case back in the late 90s of a woman on Air Canada who was immigrating from Romania to Canada, had an undiagnosed bronchogenic cyst, which exploded during the flight. She had pneumothorax and she died. So you don't want people to fly with these things. All right, next on the list is congenital lobar emphysema. Congenital lobar emphysema is tricky because when you look at imaging, all of us are trained for our eyes to look at the white things. White things in the lungs are usually bad. Congenital lobar emphysema, you have to train your eyes to look at the black things. It's the black part that's abnormal. And clearly on this one, you can see that you've got this very, very loose lung, and you clearly got mediastinal shift. And if anything, the right lung is grayer than usual because it's a bit atelectatic. And of course, one of the differentials for these things is always a pneumothorax. And the big thing to tell you apart is there should be some subtle little line markings still in these things. If it's a congenital lobar emphysema, obviously the pleural space will be completely black. It's a pneumo. But we've had cases at CHEO where patients have gone to emerge with respiratory distress. Surgery was called stat. And so this is a pneumo we're put in the chest tube, and it turned out to be congenital lobar emphysema. So CLE is progressive overinflation of at least one lobe with atelectasis of the rest of the lung. The interesting thing is if you take these things out, they don't deflate. So the normal elasticity that lungs normally have to get bigger or smaller, they really don't particularly have. Most of them are typically the upper or the middle lobes. They're for some reason common in males, and about 40% are associated with other factual kinds of things, especially cardiac anomalies. So there's lots of different things that can cause congenital emphysema. About half the time, it's just kind of there. We don't know what causes it. There's a thought that maybe sometimes the alveoli are abnormally rigid. Another possibility is you've got way too many alveoli and they just can't deflate. And that's called a polyalveolar lobe. It's in all the textbooks. I've never seen a polyalveolar lobe, but it's one of the potential causes. And then the other potential cause is if you have some type of bronchial obstruction, especially a congenital bronchial obstruction, like a web or something, it can act as a ball valve. And of course, that will lead to this level of overspending beyond it. So normally when we have a congenital emphysema and surgery wants to remove it, they'll ask one of us to do a bronchoscopy intra-op to see if there's some correctable airway lesion that we can just get somebody to open and prevent the need for a lobectomy. The other important part of this is if you imagine you've got, especially some kind of airway obstruction causing this, and then the child catches RSV. So they've got tachypnea, they've got increased respiratory distress, and there's a ball valve. Air comes in, but the breathing fast, there's no time to go. More air gets in, some times to go. And that keeps on going. And often CLEs present during RSV season. And I've had a couple of cases of these where when you call the ICU, there's this really weird looking one. I take one look at that X-ray and says congenital emphysema. And they say, no, it's not, it's RSV. And I'll say, yeah, but I'll bet it doesn't go away when the RSV does. And that's a really good way of picking up a CLE. So once again, they typically present with progressive respiratory distress, sometimes with cough or wheezing. They can have impaired mucociliary clearance, so they can present with recurrent respiratory infections. And of course, they can have mediastinal shifts. So the diagnosis, again, is usually pretty obvious. A chest X-ray should help you. You can do inspiratory and expiratory views. Usually we now do a CT scan to help define the diagnosis, look at anomalous vessels. If you're really not sure, a ventilation perfusion scan can often really help because you'll see this lung that has some perfusion, but really doesn't ventilate because lungs need to expand and contract in order to have ventilation. And once again, usually at the time of surgery, we will do a bronch. So in CT, again, this is what it looks like. And once again, it's the black part that's really abnormal. You can see there's one lobe in this patient, presumably right up the lobe, is really inflated, and there's atelectasis and depression of everything else in the chest. So in terms of treatment, occasionally use emergency surgery. That's not very common. The mild ones is controversial. Some people say you should take them out to let the rest of the lung expand and grow more. Some people say you could leave these things alone. People could argue about the mild ones for a very long time. The ones that are causing respiratory distress, typically you're going to remove. There's a couple of really terrible ancient studies where they looked at patients who either had removal of these things or didn't have them removed. These are non-randomized, awful studies. And basically, they suggest that if you take it out, the rest of the lung expands pretty well, and you have normal lung function. Okay, next on the list is congenital pulmonary airway malformation, or CPAM. For slightly older pediatric gastroenterologists like me, we used to call these CCAMs, or congenital cystic adenoid malformations. But they're not anymore in the airways, which is why they're now CPAMs. But CPAMs and CCAMs are exactly the same thing. So once again, it's in the spectrum of these bronchopulmonary malformations. Typically, it's a combination of solid areas, very tightly packed tubular structures, interspersed with cysts, which are dilated tubular structures. Sometimes they secrete mucus. They don't have cartilage or glands in them. And it's probably due to a developmental arrest around 20 weeks of gestation. And they're kind of more dysplastic and more like hamartomas than anything else. Some of the large ones can cause fetal hydrops because of rapid cell proliferation and impairment of blood flow in the fetus. So once again, these things compress the rest of the thorax. They can also lead to polyhydramnios in infants if there's compression of the esophagus. And once again, there's a small but real chance of transformation with these things. The Stalker classification has been around for forever, and Stalker has three types. Type 1, which about half of them are large cysts, not that much tissue. Type 2 are a mix of cysts and more solid tissue, and type 3s are almost entirely solid. So these things will present sometimes in neonates with progressive respiratory distress. With a lot of these malformations, there's also impairment of clearance of the fetal fluid. So often this area of opacity, picked up right after birth, it kind of gets better afterwards, is very common with any of these malformations. In older kids, these compress adjacent lung, and you get recurrent pneumonias. About 20% of other congenital anomalies. Type 2s are more likely to have congenital anomalies, about half of them do. And type 3, the solid ones, those are the worst ones. They're often fatal because you get a lot of hydrops, and they're big and they're solid, and you get pulmonary hypoplasia of the rest of the lungs. And often the type 3s end up on ECMO before you can kind of decide what to do with this baby. So overall, about a third of them are diagnosed in neonates, a third of them are diagnosed before a year of age, and the other third are diagnosed later in life, and occasionally even in adults. So there's been at least 13 cases of malignancy in the first 250 reported cases of CPAP, which works out to about 5 per 100 cases. And that's way higher than the usual rate of lung cancer in smoking adults, which is about 33 per 10,000 people. So you get this feeling that there's not many of these things, but the rate of cancer is much higher than you would expect. The commonest cancers, again, are bronchoalveolar carcinoma, especially in adults, occasionally in kids, and rhabdomyosarcoma, again, almost entirely in children. And given that lung cancer is indescribably, vanishingly rare in children, the fact that there's a bunch of these makes you get this real feeling this is one of the few actual causes of lung cancer in kids. So in terms of diagnosis, often you see this solid lesion on chest X-ray after birth. They can look a lot like congenital diaphragmatic hernias because you've got lots of little cystic-looking things. It can look a lot like bowel as well. Often these cysts get bigger over time. You get mesocecal shift. And most of the time it's a combination of solid areas and cystic areas. We basically always do the CT on these to better define the lesions. And CT gives you a really good idea of what you would see pathologically. You can do ultrasound, including prenatal ultrasound. One of the weird things about CPAPs is if you do prenatal ultrasounds, it's not unusual for these things to resolve before birth or shortly after birth. So you have to be cautious when you counsel families that you're diagnosing this terrible lesion that potentially can turn into cancer, but not infrequently they just go away, which is sort of a weird thing to counsel people about. And CT or MR angiography will help distinguish these things from the sequestration. CPAPs normally have the normal pulmonary arterial blood supply. So in terms of treatment, if you ask me as a pediatric respirologist, if they don't go away, personally, I think they should all come out. I don't like risks of lung cancer in kids. Surgery will sometimes argue about these. Some of these we follow, kind of review hesitancy. It also depends a little bit how big these things are. The bigger ones can be very hard to take out early in life. But by and large, if you can take them out, I think you should take them out. Both from a malignancy point of view and also to prevent infections. Obviously, if you get infected, they're much harder to take out afterwards. Our next malformation are sequestrations. And there's two types of sequestrations, extralobar and intralobar sequestrations. If any of you guys see the abnormality on this X-ray? Do you see it? Not the one. Well, sort of, not exactly.
The darker part. Like,
Nope. So this is an absolutely classic extra lower sequestration. 98 out of 100 look like this. And extra lower sequestrations are basically this extra little piece of lung that decided to grow all on its own. It's got their own pleural covering. It's like a bit like having a fairy lung. And almost all of them are a white triangle in the left lower lobe.
yeah.
They're pretty subtle. You can see a full of white line.
Okay, now, yeah,
Can you turn the lights on? Yeah, I was like, I don't.
Yeah. Oh, yeah, that's
It's going down.
it's gone to my head, like, to be honest.
Let's take a look.
Yeah.
Also worth pointing out that a complete left lower lobe atelectasis would also look exactly like this. Lower lobe atelectasis is like a triangle next to vertebrae. So left lower lobe would look like this. The right lower lobe would be like triangle there. Okay, but they are subtle. So extra lobar sequestrations, as I mentioned, are basically its own separate little piece of lung. One of the important things is they're supplied by an arterial plexus from the aorta. You don't want a surgeon to go in and slice these things without being very aware of the blood supply. And they contain sort of atelectatic embryonal lung tissue, some dysplastic elements, sometimes some cysts, their own pleural covering. Since they are not connected to the tracheobronchial tree, they're never aerated and they never contain air basically, so they're always solid. They're commoner in males. As I mentioned, they're nearly always in the left lower lobe. So they've got systemic arterial supply 96% of the time. They've usually got systemic venous drainage. They're also common if you also have congenital hernia. They're almost always asymptomatic. They're picked up incidentally on chest x-rays and referred to respirology. It's allergies that I do not have covered. Really rarely they can be big and cause respiratory distress. I've never seen that. Theoretically, they can get infected, especially if they're connected to the esophagus. I've never seen that either. And they're really kind of felt to be an extra piece of lung that just develops on its own. Intralobar sequestrations are a little bit more controversial. Originally, they were felt to be a separate congenital lung malformation. Then they were felt to be secondary to a lung infection that then became inflammatory, developed some blood supply. Now the pendulum has swung back. We think they are a malformation. So again, they tend to be sort of an accessory piece of lung. They're usually infected because they're sort of part of lung tissue. They get bacteria in them. They can contain bronchiectasis. They can have cysts with mucus. Sometimes we have some cartilage. And once again, there's been a few cases of ligament transformation with intralobar sequestrations. The important thing is the intralobars always have systemic arterial blood supply, but pulmonary venous drainage, unlike the extralobars, which are systemic and systemic. These ones are a little bit confusing. About a third present before 10 years of age. It's not unusual for these things to present in teenagers or in adults. And typically they present with recurrent pneumonias. You treat them a couple times for pneumonia, and the chest x-ray always looks weird. It's one spot somewhere in the middle of the lung. And on CT scan, you're kind of going to see the same. They can present with chronic sputum production, with fever, chest pains. They can present with an pneumothorax. And if they've got large systemic arterial blood supply, it can lead to clubbing and cyanosis. And most of them are symptomatic at some point. So once again, for extralobar sequestrations, I always think of the plates on a stegosaurus. That's what they look like. The interlobars are kind of a mix of solid and cystic or multicystic tissues, typically a bit more in the lower lobes. You can see a fluid level for these things. And again, it's really CT or MRI that you need both to define the size of the lesion, really, really importantly, tell the surgeons what the blood supply is before they slice anything. So again, for extralobars, I normally leave them alone, but I've never seen one run into trouble. The intralobars, typically you use antibiotics, and then you do a lobectomy. Surgeons hate intralobar sequestrations because they're not a nice discrete tissue, and you can't just do one segmentectomy or whatever. It usually involves taking a fair amount of lung to get one of these things out. But you want to remove them before they get more infected. So now we'll talk about aplasias and hypoplasias. And so you can get, this is a classic lung agenesis. There's really no lung on that side. That's the heart that's sitting there. Or you can get hypoplasia, where one lung is just smaller than the other lung. They're subtle. And again, you have to really look on the X-ray before you see these things. Hypoplasias are usually asymptomatic. We used to do adult pediatric combined respirology rounds at TOH, and I presented a series of how many hypoplasias were all asymptomatic. And the title for my talk was Lungs, Who Needs Them? So agenesis means there's no lung tissue at all. Aplasia means there's a little bronchial pouch but nothing else. And hypoplasia means basically that the airways and the alveoli and the vessels are all smaller than they're supposed to be. So obviously agenesis and aplasia is a developmental arrest. Theoretically can affect one lobe, but I guess I've seen that once. Most of these affect the entire lung. You get compensatory overgrowth of the remaining lung, and at least half of them have other bacterial type anomalies, especially vertebral, the ribs, and or spine. Agenesis and aplasia can be fairly subtle. Bless you. They can present with tachypnea in the newborn. Sometimes you get infections because there's a pouch, bacteria, and mucus can build up in those things. And when you're diagnosing these things, a really important part is take the patient's shirt off and just look at the two sides of the chest. Are they the same size? And that will often help you as well as imaging. Another important thing to keep in mind is if you leave these things alone, which is normally what we do, when kids go through adolescence and their pubertal growth spurt, if you imagine one lung is small and grows this much, and this lung is big and grows that much, what happens to the spine? It curves over. So these kids are very high risk for scoliosis when they go through puberty. So once again, X-rays, we usually do a CT scan. Occasionally they present with this huge whiteout of one lung. If people would have a foreign body, we'll do a bronch and discover there was no foreign body there, but there's no lung there either. And that's where, again, where CT can be helpful ahead of time. Hypoplasias, again, are more subtle. A lot of hypoplasias are secondary to some other anomaly. So if there's a space-occupying lesion like congenital diaphragmatic hernia or a CPAM, all of those things will cause hypoplasia. All of the trisomies can cause primary pulmonary hypoplasia, 13, 18, especially 21. If you've got oligohydramnios in utero, your Potter syndrome, that will cause hypoplasia. Sometimes you've got decreased perfusion in the lungs with congenital cardiac malformation. The lung doesn't have a chance to grow. And also, if you've got reduced fetal breathing, like an ACN type 1 or an SMA type 1 or type 2, all those things will cause pulmonary hyperplasia. Most of these will present with tachypnea. The smaller ones are smaller, so you have to breathe more to compensate for that. You get a grunting, a respiratory distress, saturation. When I'm assessing these kids, we always get called to neonates when they see one of these things. So the first thing you kind of do is look at a chest X-ray and count the ribs. And as you know, I think all of you have learned in your respirology rotation, pediatric respirologists usually count anterior plus posterior ribs. So for an X-ray like this, nobody's your top one is like 1, 2, 3, 4, 5, 6, 7, 8 posterior, 9, 10, 11, 12, 13, a little diaphragm, normal is 14. And so if you counted the ribs and there's like 8 or something, that makes you really wonder about pulmonary hyperplasia to begin with. And what I really care about pulmonary hyperplasia isn't what the lungs look like, it's how well they work. And it's kind of the equivalent that you're buying a car, it's kind of rusty, but what you care about isn't the rust, what you care about is can you drive around Queensway. And so for lungs, the equivalent of that is do you blow out CO2? So even if you've got a bit of desaturation, that'll get better with oxygen. If you can blow off their CO2, it's going to get better over time. If they can't blow off their CO2, those are the ones who really went to trouble. So with that, we're finished with congenital malformations, and the next part of the talk is tracheo-esophageal fistulas. All right, Acute, just keep going. Okay. So once again, you have that median pharyngeal groove in the front of your foregut, and that's supposed to separate into the tracheobronchial tree and into a digestive tract. And there's mesenchyme that kind of shifts between those two developing structures so that they separate. And no one's exactly sure what causes TES, but by and large, we feel that either those tissues don't separate properly, or the mesenchyme interferes and they stretch and they join back together. And the incidence of TF is about 1 in 2,400. It's not that different from the incidence of CF in a North American population. Again, Bacterial, the T and the E in Bacterial is tracheo-esophageal fistulas. So about 40% of the, well, 25% of these things have associated other bacterial anomalies. And if you pick up a TF, as all of you know, neonates will do this bacterial screen where they look for vertebral anomalies, and they look for renal malformations, and of course your kidneys and cardiac malformations. So the classification, there's 2 different classifications for T fistulas. And at SHIELD, usually we use the Voigt classification. So using Voigt, if you've got pure esophageal atresia and no TF, that's a Voigt type 2. If you have a proximal TF, that's a Voigt type 3A. If you have a distal TF, that's a Voigt type 3B. If you have 2 TFs, that's a Voigt type 3C. And an H type would be a gross type E. About 85 to 90% of T fistulas are in distal tracheoesophageal fistula. By far and away, you'll see more of those than any of the other ones. When you're looking at the operative notes for surgery, you always try to figure out which type of TBF it is. I think I've seen every one of these at some point in my career, so they all happen, but most of them are going to be 3Bs. So, why do I care about tracheoesophageal fistulas? And the answer really is this slide. So it's one slide to remember about TFs. This is the slide to remember. So in all of us, you have your trachea, which mostly has a kind of C-shaped cartilage, little membranous portion at the back, where your esophagus behind it. If you have a tracheoesophageal fistula, somewhere along the lines, these 2 things are going to join. The result of this could be a couple things. The first piece is you have this kind of U-shaped tracheal cartilage with this long membranous portion. If you smile, every time this child coughs, this thing vibrates like a clarinet reed. And everybody in the TF has this incredible, loud, vibratory cough that they have for life. Every time they cough with Walmart, everyone moves away and think they've got COVID. Second, if it's severe, every time you cough, this thing collapses, you can't clear secretions, you get recurrent pneumonias, and that's what we would consider to be clinically significant tracheal. The second problem you have is in neural, there are neurons that migrate through the whole of the esophagus, forming myocardial plexus. Neurons still leak across gaps. These patients never have normal myocardial plexus. So the normal kind of plexus, these sort of neural network. So when you get a Mars bar, that Mars bar starts off at your mouth, and your esophageal contractile waves moves it down your stomach. These patients don't have. So that Mars bar can sit in the upper esophagus, and they can aspirate. Secondly, your lower esophageal sphincter is very dependent on normal contractile waves to open and close. If those waves are there, it opens whenever it feels like. And then you can get GERD, you can aspirate from below. And like any surgical site, after you repair these things, occasionally the surgical site will break down. You get a recurrent tracheo-esophageal fistula, and you can aspirate from the middle. So TFs are like the human paradigm of aspiration. Any way a human can aspirate, they can aspirate. And the key message I want you guys to get from this is when you see a child with a history of TF and they've got respiratory stuff, before you chalk it down to asthma, send them home on hoppers, think about all these possibilities, because all of them have to go away. So, in terms of esophageal complications, obviously the first big one is going to be impaired esophageal motility. After they do the initial repair, it's common to get esophageal strictures. They can get recurrent TS, we talked about. They can get GERD. One of the tricky things is if you've got really bad GERD, surgeons sometimes think maybe do a fundoplication, just tighten the lower esophageal sphincter, treat the GERD. The problem is if you've got lousy esophageal motility and you're trying to move stuff from the esophagus into a very tight lower esophageal sphincter, you can actually make your aspiration worse. When they do a fundo, it's not very often anymore. They often will do a leaky fundo to prevent that loose fundo. Good news with strictures is they're really common in the first years of life. They get much, much less common as you get older. So you often see kids with multiple emissions in the first years of life, not so much as they age out. Another more recent complication to recognize with the esophagus is actually eosinophilic esophagitis. And we have a real sense now that if you have enough food sitting around in your esophagus long enough, it's not going anywhere, you probably get more allergic sensitivity to it. And that's not an unusual complication of this population. In terms of respiratory complications, tracheomalacia is common. We've already talked about that Brophy cough. They can get recurrent wheezing. If they have really bad tracheomalacia, they can actually block off their airway in babies and get recurrent TF spells, which can be very severe. Again, if you've got tracheomalacia, it impairs mucociliary clearance, and bad tracheomalacia is associated with a much higher risk for recurrent pneumonia. These patients also have a higher rate of laryngeal plaques, and since they're doing a lot of surgery to mediastinum, they've got a higher rate also of vocal cord paralysis post-op. So in terms of pulmonary outcomes, as a result of this sort of poor mucociliary clearance, chronic cough is common, recurrent pneumonia we've talked about. Lung function on average tends to be the lower end of the normal range, but with lots of variation. About 25% of TF patients do have abnormal airway reactivity and abnormal like asthmatics. But it's a diagnosis of exclusion. You want to make sure that they don't have airway reactivity because they're aspirating, and they really have airway reactivity because they've got eosinophilic inflammation in their airways and classic asthma. Another reason why this is important is if you imagine you've got a floppy trachea, lots of tracheomalacia, sometimes the only thing keeping that trachea rigid is a little bit of bronchospasm in the trachealis muscle. And if you give them a bronchodilator, their airway actually gets floppier and the tracheomalacia gets worse. So if you emerge and you see the patient with fistula and they're wheezing, try gingerly giving some Ventolin and see if it makes them worse or better. If it makes them worse, stop it. So once again, the nice thing is TF tends to be more of a pediatric problem than an adult problem. And when you look long term, rates of bronchitis steadily decrease over time, your cough gets a bit better, this is about the same. The rates of pneumonia go down. But these things are still all commoner in adults with TF than the general population. And same with hospitalization rates, you can see much commoner in kids for both GI and larger hospitalization than is the case in adults. So in terms of long-term outcomes, one of the important complications from TF that we now know is bronchiectasis. So a big part of the name of the game in TF is preventing bronchiectasis. And that's by preventing aspiration. So think of all the ways that these kids can aspirate, and controlling that is crucial. We've talked about eosinophilic esophagitis. Again, as a result of chronic GERD in adults, they have a much higher rate of Barrett's esophagitis, and they have a significant rate of esophageal cancers. So in terms of management, the first step is diagnosis. So if you're worried about fat tracheoplasia, bronchoscopy, looking at how bad it is can be very helpful. In terms of managing tracheoplasia, for really bad ones, people in positive pressure ventilation as a neonate, or we send them home with an ambu bag during TF spells. We generally avoid subunimols, we've talked about. Especially as these kids get older, they really benefit from chest physiotherapy to help clear secretions out when they're sick. And when they're old enough to do it, the best form of physiotherapy is called a PET mask. So a PET mask, you guys may remember from CF clinic, it's basically breathing into a very, very tight resistor, builds up a lot of positive pressure in your airways, helps split those tracheobronchial airways open so you can clear your secretions. Some of these kids with the tracheoplasia will get recurrent croup. So we manage that the way we treat anybody else with recurrent croup. You either give us a small supply of Dex to have in the house, or you give them high dose nebulized budesonide, shrink those airways down when they're sick, and give them more space for breathing. And obviously, the key immunizations become really important in this population. In terms of the GI side of things, one of the important things is know how to investigate these kids. And the way you investigate the three different ways they aspirate is all different. So if you're worried about aspiration from above, a feeding study may help you. An upper GI is going to help you. It'll show you what the esophageal motility is doing. Some centers will do manometry to look at this as well. For recurrent TEF, the way you diagnose it, by and large, is with a pullback study. Just to remind you guys, a pullback study is not a pleasant test. So the way you do a pullback study is you put in a Foley catheter into the esophagus, you blow up the balloon, you put in a second catheter above your Foley, you inject barium into that second catheter, trying to move, have it go into small threaded little recurrent fistula. You gradually bring both catheters up and see if you can force the barium into a small fistula. It's actually a better test for recurrent fistula than a bronchoscopy or an esophagoscopy, which can miss these things. So we talked about aspiration from above. We talked about a recurrent PF or an H-type. For diagnosing GERD, obviously the gastroenterologists are better at this than I am. Most of the time, we do a trial therapy with PPI. You can do a nuclear nerve scan. There's other tests you can do for a pH impedance, but all become important to be thought about. In terms of managing this, there's really no good treatment for esophageal dysmotility. Probably the most useful thing you could do is what's known in our TF clinic as the Dr. Kovesi and Dr. Markey and Dr. Evers TF goals. And our rule is if you have poor motility, you eat a little bit, drink some water. Eat a little bit, drink some water. And the foods to really worry about are things that get hard in your esophagus. So hot dogs, steak, white bread, those are things to be really careful about. And one of my classic stories was one of my patients with TF was eating Kraft dinner choked on his dinner, went to emerge gabino extremis, extreme respiratory distress. There happened to be an ENT surgeon in emerge and gabino when the child was there. Did an emergency laryngoscopy, and the craft in the noodle was lined up in parallel in his larynx. And he was breathing through little holes in the craft. So aspiration is a real issue for these patients. I really think these kids should be followed in a TF clinic with surgery and GI and respirology. So as all of you know, we have a TF clinic here at SHIO, and anyone who uses with TF, especially for being discharged from neonates, if they're not connected to the TF clinic, refer them. You want to see all of them. The hard part is I think all of these patients should also be followed in the adult TF clinic. And those don't really exist in very many places yet. But as a bare minimum, I think all of these patients in the age out of pediatric age group should be referred to respirology for long-term follow, and especially to gastroenterology for long-term follow.
Wonder how it go back. You also present like their virtual clinics that you guys do them, or how does it work with?
We're bringing them down. Getting them to multidisciplinary is the best way to do it. All right, I think that's the last slide. Yeah. So, any other questions? Yeah. Yeah, EOE is common in TF patients. So when you're seeing a patient with dysphagia and or a stricture, important purpose, you have to do endoscopies and get biopsies to diagnose whether it's GERD or whether it's EOE. And as these patients grow up, they need routine surveillance endoscopies by GI for life to make sure they're not getting Barrett's esophagus. Well, we finished on time.
But like, you know, which one? So they're not up. It won't let me.
No, I love that.
Yeah.
I don't know, like, no, I have class, I already did this. You already did that?
Yeah.
Like, I was looking at
I'm so bad at remembering this address. I'm so sorry. Can I do a pen? Sorry. Yeah. Sorry. I'm so bad. Yeah. My past really same as
Any people online?
There are people online, yes.
Whose stick is this? So I didn't save it. I'd rather keep it.
It will show. You just have to upload it from the key.
I got a page. About the consoles have more north and lines on the left circle the line so that they can get to it. You guys been talking about it, but she just wanted to touch base and see if you had more time to think about it.
Hello. So, yeah, sorry. We discussed it in rounds, and we all agreed that the lecture. I'm sorry, I've just been busy since last rounds and thanks, and apologize to the She knew.
I love this part.
Thank you.
We love it.
Sorry.
Thank you.
They shouldn't be paging you.
Yes, it's
Why are they paging you?
I have no idea.
Thanks.
Probably I'm gonna do it. Oh, no, you're such a
Okay, guys, sorry about that. I'm distracted. I was supposed to be on call this week when I agreed to do this talk, and then I switched to call with somebody and saw this on my schedule. I was like, oh, that's not good. But hopefully this will be straightforward, and I don't think it'll require the full half an hour. So I come to talk to you before about HIV and congenital infections. So this was just a mop-up. We didn't quite finish the hepatitis B and C section. So there are not a huge amount of things that I think you as general pediatricians need to know about these infections, but we'll try to cover the main points that I think everybody should be aware of. So we'll start with hepatitis B. So this is an infection that is super prevalent. People always think that HIV is like the most common thing globally, but hepatitis B is about 10 times more common than HIV. There's about 250 million people living with chronic hepatitis B, 1.2 million new infections per year, and that counts for about 1.1 million Hep B related deaths annually. And as of 2022, only 13% of people who had hepatitis B were aware of their infection, and only 3% were on treatment. Not everybody needs treatment, so that's not the end of the world, but probably more than 3% need it. And the proportion of children under 5 who are chronically infected with Hep B dropped to just under 1% in 2019. to just sort of versus 5% in the pre-vaccine era. So, you don't see that good. So like over the last 15, 20 years, the WHO has rolled out birth dose hepatitis B vaccination campaigns, and that's to address the issue of perinatal hepatitis B transmission risk, and especially in countries with high prevalence. You can see the countries with the darker colors are ones with hepatitis B surface antigen positivity greater than 8%. So pretty significant portions of the world. And then we usually think of like East and Southeast Asia as being the most prevalent, but you can see that there are countries in Africa that are more prevalent than most of Asia. So yeah, 6% surface antigen positivity in the African and West Pacific regions, 3% in Eastern Mediterranean, 2% in Southeast Asia, 1.6% in European regions. And then when we think about Canada, an estimated 250 to 460,000 people living with Hep B in Canada. So not an uncommon infection. By comparison, we have about, there's been about 90,000 people diagnosed with HIV over the last 40 years. I think only about half of them are alive. And so about 10-fold higher numbers of people with Hep B than with HIV. So we're pediatricians, and so what do we think most about? That's perinatal hepatitis B infection. So risk of developing chronic Hep B infection after an acute infection is highly dependent on when you get it. So if you get it as a newborn from your mom who has it, there's a 90% chance of babies whose mothers are Hep B E antigen positive getting it. 90% of newborns who acquire Hep B at birth will keep it. Like it'll become a chronic infection. About 25 to 30% of infants and children under 5 who get it, and that's probably almost as common as perinatal transmission. So that kids pass it around within households or within playgroups. So that horizontal transmission, which is usually through saliva, happens almost as frequently as perinatal infection. And so the hepatitis B vaccine campaigns, adding it to young children's vaccine series is a really good idea because it prevents that horizontal transmission postnatally. But if an infant or young child gets hepatitis B infection, there's about a 25 to 30% chance that they will remain chronically infected over time. And then if an adult acquires hepatitis B, there's only about a 5% chance that they remain persistently infected. The rest will clear it spontaneously. And so why is this important? It's because chronic hepatitis B infection carries a risk of multiple complications, the biggest being cirrhosis, hepatocellular carcinoma, and liver failure. And so these are things that we want to prevent, and people who acquire and the risk of these complications is associated with the duration of infection. And so if you get hepatitis B as a baby, then you have 80, 90 years to develop these complications. If you get hepatitis B as an adult, like at age 30, then you have 50, 60 years of time to get complications. So preventing perinatal infection is really important. Having worked in Africa and Asia a lot, I've actually encountered many young people who died of hepatocellular carcinoma, which you don't ask, but I assume that that's related to chronic Hep B infection in childhood. And so this is something that really we want to prevent and can easily prevent as long as we do the right things. And so like I said, the WHO recommends infant Hep B immunization with a birth dose for this reason. And then probably everybody here has seen a newcomer from Cameroon in the last 2 years. I feel like there are no people left in Cameroon. They all moved to Banye. I literally have entire clinics full of people from Cameroon. But And so Cameroon is like many of the sub-Saharan African countries. Their primary series of vaccination is 6, 10, and 14 weeks. They get the equivalent of our penticillin, so it's like diphtheria, tetanus, pertussis, Hib, and hepatitis B, and then they get oral polio. Sometimes they get both oral and injectable polio, but the primary series in almost all African countries includes hepatitis B at 6, 10, and 14 weeks, which is equivalent to our like 0, 1, and 6 month schedule, but it won't help a baby who's exposed perinatally. So the birth dose is helping those ones whose mothers have hepatitis B and don't know about it, or do know about it and don't have access to other treatments. In Canada, I think we're one of the only provinces and territories that don't give the vaccine to babies. Most other places, including the ones that we are catchments for, so Quebec and Nunavut, both have birth dose hepatitis B vaccination. I do not know. No, that's not true. Quebec has their 2 and 4 month vaccines are hexavalent with Hep B, and then they give a booster dose with Hep A and B at 18 months. So they don't give birth dose vaccine, but they do give infant series. Ontario does not. We give it in high school, which I think is a bad thing. I've been complaining about it for years, but no one who makes these decisions listens to me. All right. So if a mom does have chronic hepatitis B, the risk of perinatal infection without any intervention is depending on her amount of virus in her blood. So we talk about E antigen positivity and surface antigen positivity. So surface antigen positive means you're chronically infected. E antigen positive correlates with high levels of viral production. It's an old test that we don't really rely on as much anymore because nowadays we rely more on viral load. And a viral load of over 200,000 correlates approximately with being E antigen positive, and those represent higher risk for perinatal transmission. And so if a mom is both surface antigen and E antigen positive, meaning she has a high viral load, there's a 70 to 90% chance of perinatal transmission, versus if she is surface antigen positive but E antigen negative, the risk is about 5 to 20%. Giving the vaccines alone in this scenario reduces the overall risk of infection by 70 to 90%. And the addition of hepatitis B immune globulin reduces the risk in surface antigen positive E antigen negative mothers to less than 5%. It's probably like much less than that, probably like more like 1 or 2%. But it's not 100% effective. But if the mom is E antigen positive, meaning she has a high viral load, even with HBIG and vaccine, there's still a pretty significant residual risk of infection, like 7 to 9% from some series. And so that is why HBIG is important. And it's also why moms getting tested in pregnancy is important. I'll come to that. And so when you guys, I know you guys see the babies when they're born, when you're on call over at the General or the MO4 or Pacific or wherever. And so I always explain it to moms that we give 2 injections. One is the vaccine, but the vaccine doesn't work right away. And so until the baby generates an immune response to the vaccine, we want to protect them with other people's response to the vaccine, which is what the HBIG is. It's a deactivated and sterile hepatitis B antibody product. And so, yeah, I find if you explain it that way, people tend to accept it. If you come at it as like, I need you to sign this blood product form, like people tend to get a little more freaked out. But the antibody products, HBIG, measles immune globulin, IVIG, sub-Q IG, all of those are sterilized. They're heat treated and detergent treated, so they're very, very, very safe. Once a baby has received HBIG and vaccine, there's no contraindication to breastfeeding. Although we should mention that if a mom has like cracked bleeding nipples, that might represent a higher risk of transmission, and maybe she should hold breastfeeding on that side until it resolves. So the thing I wanted to impart to you is that things have changed. Like from when I was training until now, things have changed. Like it used to be, we screen women who are pregnant for hepatitis B surface antigen, yes, no, and if they're surface antigen positive, their baby got HPIG and vaccine. But now, since like 2018, there's been clear guidance from this is the AASLD, the American Association something Society for Liver Disease. They put out recommendations that suggest that any woman who is surface antigen positive should have a viral load done in pregnancy. And if her viral load is greater than 200,000, then she should start treatment. And the indication for treatment is for perinatal prevention. And it's recommended that she start antiviral therapy. This says 20 to 32 weeks. I think even if it starts as late as 34, 36 weeks, that should be enough time to get the viral load down. But yeah, so every pregnant woman who's surface antigen positive should have this testing done. And normally people who have chronic hepatitis B from childhood, they should have like low viral loads, but things change over time. Like I've seen women go from like being like surface antigen positive with a viral load of 20 to like flaring up into the like 100,000 range, and things can change. So it's important that they should be checked during pregnancy at least once. And then the AASLD recommends against using antiviral therapy for perinatal transmission if the viral load is less than 200,000. Nowadays, the indications for treatment of hepatitis B have broadened significantly. So there may be other reasons that a mom started on hepatitis B treatment other than perinatal prevention. And like that would include things like hepatitis flare, like if they have a flare of their liver enzymes, if they have co-infection with HIV, with hepatitis C, with hepatitis D. The hepatitis D is a kind of like a weird parasitic kind of virus. You can only have hepatitis B if you also have hepatitis. You can only have hepatitis D if you also have hepatitis B. It's like obligate. So if someone has hepatitis D, then they should go on treatment as well, because all those co-infections tend to have worse long-term liver outcomes. So they're indications for treatment. Okay, so what do we need to do for the baby? So we need to, if a baby is born to a mom with hepatitis B, the baby should get the HPIG and the first vaccine within 12 hours of delivery. I'm sure you've all been asked to come see these babies and order the HPIG and get the consent. It's important to, and then they get the second and third doses at 1 month and 6 months. It's important to remember that if a baby's under 2 kilograms, they should get an extra dose at 2 months of age. And then, yeah, they should be referred for follow-up. Here in Ottawa, I offer to do it. I offer to see the babies for their vaccine because so many people, especially newcomers, don't have a family doctor. I've seen many people fall through the cracks where they're discharged from hospital and you tell the family, oh, you need to call public health and make an appointment. And like it's putting a lot on people, especially if they don't know like what's going on or how to arrange things, for them to like be able to navigate our system in Ottawa to find someone to give them a vaccine. I had one family where there was a set of twins and the mom was very, like she'd been here for a long time and she was a very skilled and capable, and she could not find a place to get hepatitis B vaccine for her kids. She drove all the way back to Hamilton. She had lived in Hamilton before she moved to Ottawa. She had a family doctor in Hamilton and she couldn't get in anywhere here. And she drove to Hamilton 6 hours to get her babies vaccinated. Late at 2 months of age, because she tried for a month, like 2 months here. And then she couldn't find any place to get the 6 month vaccine. And so she just randomly called up our clinic. We're like, yes, you can come. So I would ask you, if you see a baby while you're on call who doesn't have a family doctor, or even if they do, feel free to send a consult to our clinic for follow-up. That won't be the case in all places, but I feel like in Ontario, we have a real lack of primary care, and these kids could fall through the cracks, and that's not appropriate. Public health in Ontario, in Ottawa, will send me a referral if they get a request for the HBIG, and they see that there's no family doctor. Then I've asked them to send me a referral, make sure that it happens. But there's still kids that fall through the cracks, including here. Like I've seen a bunch of kids admitted here to GEO in the newborn period, and people recognize that they need Hep B vaccine, and then they try to send them to the Kids Come First like vaccine thing, and then they can't get in anywhere for like 2 months. Again, not appropriate. So the other thing that I think is really important that a lot of people don't do is these babies need follow-up testing. So I told you that if someone's chronically infected with hepatitis B, their long-term risk of complications is very high. Even if there's only a 1% chance of a baby getting hepatitis B despite appropriate management, it really should be diagnosed. And the other thing is not everybody responds to their first, sorry. Hello? Yeah. Okay. You could try teaching and see what just your van is not available for some of this. They should all know about it. Okay. Okay, thanks, Mike. All right. Oh, they should be tested. So yeah, they should have testing, and the AAP and the CPS recommend that babies who are Hep B exposed should have testing with surface antigen for infection and surface antibody for protection at about 9 months of age. The Red Book recommends 9 to 12 months of age. As long as it's at least 1 month after the last dose of vaccine, that's fine. I will warn you, you might have this happen. I've had it happen to me several times now. If you give someone the Hep B vaccine and then you do Hep B testing with surface antigen, like within like 1 to a few weeks, it can come back positive because the vaccine contains surface antigen. That's what you want the antibody production against. So I've had several people look like they had hepatitis B infection, but they just had the vaccine and then we tested them too early. So that's why we want to wait at least a month after the last vaccine, both to reduce the chance of the surface antigen still being there and also to give time for an adequate immune response. What's an adequate immune response to hepatitis B vaccine? Greater than 10 international units. Some places say 10, some places say 12. Usually you'll see like it'll be in the hundreds or thousands. Like people who've just had their vaccine, it's usually quite high, but as long as it's over 10, that means that you've had an adequate response and you should have memory against it for the rest of your life, unless you become immune compromised. And then if someone is infected, then in our center, it's usually GI that follows chronic hepatitis infections, B and C, although I'm trying to get into it, I'd like to see, but they should be referred to someone for ongoing follow-up. And then if you see a mom who has hepatitis B, they should be followed as well. So anyone who gets referred to me and I see that the mom isn't being followed by a hepatologist or an infectious disease doc, I make a referral to the viral hepatitis clinic at the general. And they basically are seen once a year. They get blood work once a year. They get a fibroscan, which checks for liver fibrosis, and they get ultrasound for hepatocyte. Like I think they get alpha fetoprotein for liver cancer screening. Like I said, the approach to treatment of hepatitis B has kind of changed a lot over recent years. And like WHO, usually the WHO is like the bare minimum. The WHO has become like the most liberal treatment guidance, which I think is really progressive. in that basically they recommend, like there are many different reasons why someone could start treatment for hepatitis B, including findings of fibrosis on FibroScan. There's a blood work score that you can use for fibrosis. It's called the APRI score. It uses ALT and platelet count and one other measurement to calculate a score for fibrosis. If their hepatitis B viral load is over 2,000 with evidence of liver inflammation with ALT elevation, that's enough to start treatment. If they have the co-infections, like I mentioned, HIV, Hep B, or Hep C, if they have a family history of liver cancer, immune suppression, comorbidities, like diabetes or extra hepatic manifestations, those are all now indications for treatment. Let's get through that. And then just to go through the testing. And so surface antigen suggests active infection. Core antibody, so anti-Hep B core antibody, means you've had infection at some point. So like if someone is surface antibody positive, surface antigen negative, core antibody negative, they just had vaccination. If they're surface antibody positive, core antibody positive, surface antigen negative, that means that they had hepatitis B infection and cleared it. If they're surface antigen positive, core antibody positive, surface antibody negative, they are chronically infected. For some reason, they don't make surface antibody while they have surface. And for the people who are getting over their infection, there's like this crossover period where they can kind of flip back and forth between being surface antigen positive and negative, and surface antibody negative and positive. It's kind of interesting, but it's confusing. So, but all that to say, like if you're seeing a newcomer, like the newcomer screening that we do includes all three, because we want to know, did they have vaccination and are they protected? Do they have infection that's chronic infection? Do they have resolved infection? And the last thing I'll say about that is people who've had resolved hepatitis B that are core antibody positive but surface antigen negative do have a risk for it to come back. Usually that's only in the setting of significant immune compromise, like bone marrow transplant. But usually people who have bone marrow transplant who have evidence of previous hepatitis B infection will go on tenofovir as an anti-Hep B antiviral to prevent them from getting reactivation. Yeah, and then this is just another, there are a bunch of different, all the societies have different recommendations for treatment, which I find annoying. In Canada, I think they have Canadian guidelines, but I found them very hard to interpret. The AASLD ones, and then there's an EASL one for Europe. They're all a little bit different, but basically they incorporate the level of inflammation in terms of the ALT. They look at the viral load, and they look at liver fibrosis. And that's what makes your decision for treatment. And then there are a number of anti-Hep B treatments now. There's the main one is tenofovir, tenofovir disoproxil fumarate. There's a newer version called TAF, tenofovir alafenamide. That one has less toxicity, like TDF can cause liver or can cause renal and bone toxicity. And so the TAF one is more gentle on the bones and kidneys. But those are the two main ones, and those are the ones that would be recommended in pregnancy if a woman had a high viral load. Then there are other ones like entecavir, telbudine, I haven't used that one, and then adaptavir. And then these are the EASL ones, which are kind of similar but slightly different. All right. So, any questions with hepatitis B? That's enough. Okay. So, oh, yep. No, if they've not received immunoglobulin vaccine, then we would be worried about Hep B transmission through breastfeeding. Like say like a woman with hepatitis B adopted a baby, and that baby hadn't gotten HPIG and vaccine, then yeah, we would want the baby to be vaccinated. It would be unusual that they wouldn't get vaccinated or HPIG, but we say if they've been HPIG'd and vaccinated, then they can breastfeed. The reverse, I've never seen happen, but good question. Okay, now we'll talk about hepatitis C. So the CPS has a nice statement on hepatitis C infection in children, infants and children. I think, yeah, it's from 2021. There was a previous one, and this is the updated version. And so globally, hep C infection is about 1%, with higher rates in some countries. Egypt had a really big hepatitis C problem, which was the origin of that is very interesting. It's a little factoid. So in Egypt, they were trying to eradicate schistosomiasis, and they were giving injections of an antiparasitic, but they were reusing needles. And so they actually amplified hepatitis C infection in Egypt as part of this anti-schisto campaign. Interestingly, that happened with HIV as well. So they think that part of the HIV has been around probably since the 1920s. They feel like that's when the significant jump from primates to humans happened. But it really didn't take off because you only see rise of that infection in populations once it exceeds 1% in the general population. And that didn't happen for many decades. And then they think that there was an amplification event in the Congo in the 50s, 60s. It was when Belgium was trying to build up the capital city, Kinshasa, and they brought in all these workers from the like jungles, like in the rural areas of Congo, and they brought them into the city, and there were a lot of demand for sex workers, and there were syphilis outbreaks, and so the Belgian nuns were treating the sex worker women with penicillin, and they were reusing needles, and that was thought to be the amplification event that led to HIV exceeding that 1% level that really allowed the HIV epidemic to begin. So we think we're doing good, but not all. So anyway, now we know better, hopefully. So yeah, higher rates in certain countries like Egypt, Gabon, Mongolia, Pakistan, Russia, Uzbekistan. The estimate for Canada was around 0.6%. However, one Canadian modeling study that took vulnerable populations into account suggested a seroprevalence of almost 1%. And intravenous drug use with syringe sharing is implicated as the main predictor of infection. There has been documented sexual transmission of hepatitis C. It's mostly in the setting of HIV co-infection. Somehow, either that increases the amount of hep C in sexual fluids, or maybe increases the risk of transmission. But all that said, there's now, in the last 5 years, I'd say, there's been a lot of advocacy to add hepatitis C serology to routine prenatal screening. And I find that the obstetricians here in Ottawa have taken up that recommendation. I don't think that's the case everywhere, but I'm happy to see that they have, because you'll find cases that you weren't expecting. So the vertical transmission risk of hepatitis C from a positive mom to her baby is about 6%, 5 to 6% is the estimate. If a mom also has HIV, then that doubles the risk to about 10 to 12%, if her HIV is under poor control. Other factors that seem to be correlated with higher vertical transmission risk include higher hep C viral loads, elevated ALT in the year before pregnancy, maternal intravenous drug use, fetal scalp monitoring, long rupture membranes, infant female sex, and being the second born twin. That said, there is no recommendation against vaginal delivery or fetal scalp electrode monitoring. Those interventions have not been shown to reduce transmission. So if a baby does get, so yeah, when we see a woman with hep C, there's nothing to offer her really. That might change in the future, but at present there isn't anything to offer her in terms of reducing the risk. But I like to see them to counsel them about the baby. So if a baby does fall in that 6% who get chronic hep C infection at birth, there's actually about a 20 to 30% chance that they will clear the hep C spontaneously. And this is also true in adults. Adults who get hepatitis C have about a 20 to 30% chance of clearing their infection without treatment, which is good. So sometimes you're lucky. Usually that will happen by 2 to 3 years of age, with recurrence of viremia being very rare. Of the children who don't spontaneously clear, about 2/3 are asymptomatic with intermittent viremia and normal ALT levels, no hepatomegaly. The remaining third do have a chronic active hepatitis C infection with viremia and elevated ALT. But historically, children with chronic hep C show no symptoms. And in the past, we would have said, like a kid who had hepatitis C, they would be followed by GI or ID annually, but they normally wouldn't see any complications of their hepatitis C until adulthood. And that's when they would be treatment eligible with the old treatments, but that's changed. Nowadays, treatment, so we had the old treatments were like pegylated interferon, which is an intramuscular injection, which caused a lot of side effects, mostly psychiatric side effects that made them really depressed. And it caused flu-like symptoms because interferon is what our bodies produce when we have the flu, and that's why you feel achy and gross. So imagine being on a treatment that gave that to you for months and months. Not good. So usually they would combine pegylated interferon with ribavirin, which is what we used to use for resp. And so it wasn't a very well tolerated treatment. Most people couldn't hack it and stop. But nowadays we have new drugs. They're called DAAs, direct acting antivirals, that are extremely well tolerated and extremely effective. And so the AASL, American Association for the Study of Liver Disease, I didn't know the study. So AASLD and the IDSA, Infectious Disease Society of America, put out their hepatitis C guidelines. And for children, we'll start with pregnancy. So in pregnancy, it's not, if a woman knows she wants to get pregnant and she has hep C, they recommend for her to be treated before she's pregnant, if she can hold off. If she falls pregnant and has hepatitis C, at present, the recommendation is against treating in pregnancy. But the new DAAs, a number of them are thought to be very safe in pregnancy. And so some people are taking advantage of the opportunity of pregnancy being a time when women tend to be more engaged in care and treating them. Because what you'll often see is women with hep C, often, not everybody obviously, but often they have intravenous drug use history or like active or past. And so oftentimes they struggle to remain engaged in care, but they tend to be more likely to stay in care while they're pregnant. And the DAA treatments are oral, extremely well tolerated, either 2 to 3 month courses. And so some people are treating women while they're pregnant, exposing the babies to the treatment because it's good for the mom. And they're trying to follow these babies who were DAA exposed in pregnancy to see if there are any long-term outcome differences, but it's still ongoing. And so, yeah. So these are the SOFLED, so that's sofosbuvir, the ledisapavir. I can't say these DAA. That's one of the combinations. Sofosbuvir, valapavir is another one, and then glecaprevir, probentasvir is the other one. So those three are thought to be safe in pregnancy from what animal models show us. And so there's studies ongoing about whether we can use them or not. So look for that in the future. So how do we follow up the babies? So we know that hep C antibodies in the infant will be present from the mom, and they tend to persist up to about 12 months. About half of babies will have lost their maternal antibody for hep C by 6 months. About 95% by 12 months, and 99% by 18 months. So in the old recommendations, the old CPS recommendations, they said that you didn't have to do PCR testing, you could just do antibody testing at 18 months. I always thought that was a crap recommendation myself, because then you're letting these parents like worry for 18 months. A, or B, they palliative care. And I see this with a lot of families where they're like, my kid's fine. They don't, they can't have it. They look too well. No, actually, most of these infections, you can't tell that people have them. So having a PCR test earlier on can reassure both you and the parents. And so I've always offered a PCR test on baby between 2 and 6 months of age, and then an antibody test at 12 months. And so now that's what the CPS recommends. They caught up to me, or they finally agree with me. And so I have seen a couple of babies where they're in the NICU and people know that their mom had Hep C, and they send a PCR test at birth. So there's no testing for hepatitis B or C at birth. But the transmission, like the incubation period, is quite long for these two infections. So you might do the test and it's negative, but it's not actually helpful. So the testing should be later for both of these infections. And then, yeah, a negative PCR result after 2 months of age usually means that vertical transmission didn't occur, but serology should still be performed at 12 to 18 months. In the US puts out a lot of guidance, and I find that their guidance is very practical in nature, but not always satisfying. So I think the latest Hep C guidance from the US said that if they have a negative PCR, they don't need antibody testing. I'm a neurotic person. I like to have everything finalized, and like everybody knows what's going on. And so when you can do an antibody test to show that the antibody is negative, then you're sure that things are finished. And it's the same with HIV. They recommended that HIV serology at 18 months isn't necessary anymore, but most of us still do it. I didn't mention, but if a mom, and this happens fairly often, if a mom has Hep C antibody, but has negative PCR, that it looks like she's cleared her infection, right? But oftentimes you only get that Hep C PCR in pregnancy, because they get Hep C testing for pregnancy, and then they get the PCR testing in pregnancy, and it's negative, which is good, but you don't know when she cleared it. Like, did she clear it a month ago? Did she clear it 5 years ago? So I still see those babies for follow-up testing, just if I can't be sure. If mom had a negative PCR before pregnancy with positive serology, and she hasn't had any ongoing risk activities like sharing intravenous drug needles, then I would say the baby doesn't need testing. And this is the table from the CPS statement in terms of like the testing approach. Like if Hep C antibody results, if RNA results, what do you need to do? And then in terms of treatment, so for those unlucky 6% of kids who do get hepatitis C, like I said, 20 to 30% will resolve it on their own. Now the DAAs, the direct-acting antiviral drugs, are approved in children down to 3 years of age. And so what's recommended is that those kids be followed up to age 3 with PCR tests and liver enzymes and ultrasound. And if they still have Hep C viremia at 3 years, then they would be eligible for treatment. And these 3 combinations, which are the ones I tried to say before, are all licensed for children now. The one that we have available in Canada that I know of is the second one, the GP, glucoprevir preventosvir, or Maverick, and I've used that one at least once. So, and they're available in granules, so they're child friendly. Imagine, yeah, this is what they look like. They're really tiny little granules that can be mixed into soft food, and the child takes them. And so there are a couple of really nice studies of this GP combination for children 12 to 17 years, and then children 3 to 11 years. And I won't go through the details of it. Basically, they looked at 8 weeks of treatment, which is the same as adults, and they found 100% effectiveness in clearing Hep C for the older children, like 12 to 17 years, and almost 100% for the younger kids, and the ones that failed were the ones that didn't take it. You might have met some children who don't like taking meds, so that happens with Hep C too. And so if they take it, it makes it go away. And there are several different genotypes. So there's GT1234. So those genotypes for the old drugs, the ribavirin and interferon, there used to be differences in response rates by genotype, but the DAAs are pan-genotypic, meaning they treat all of them. I think there's like some reduced response for one uncommon genotype from Asia. I can't remember what if it's GT5 or 6, but it's not very common in Canada. All right, so here's my summary of these are the things that I think you should take away from this lecture. 1, Hep B, pregnant women with chronic infection, surface antigen positive should have a viral load in pregnancy. And if it's over 200,000, they should start treatment with tenofovir. 2, babies who are exposed should have H-Big vaccine at birth within 12 hours of birth, followed by completion of their vaccine series at 1 and 6 months, plus or minus 2 months if they're under 2 kilos. Babies should be tested for surface antigen and surface antibody at 9 to 12 months. Hep C is slowly becoming the standard part of prenatal screening. No treatment recommendations in pregnancy yet, but I foresee that changing in the near future. Babies should be screened with Hep C PCR at 2 to 6 months of age and by antibody at 12 to 18 months. And treatment for children infected with Hep B and Hep C is available. And if you find someone with one of those chronic infections, you should refer to ID and or GI. Any questions? No questions is okay too. Any online questions? Sorry.
No, thank you, Dr.
Okay, thank you. All right. Have a great rest of your day.
Thank you.